up, and thanks everyone for being here. These are always a nice opportunity for me because I think it's really hard. We have 10, 15 minutes with a patient in the office. So I think it's really hard to kind of go through everything they need to know, and you really never get everything, but about hip and knee replacement. And so I think if patients can come in with just a little higher of a knowledge base, then we can really kind of get all their questions answered and make them feel really comfortable. So that's really one of the biggest parts of my job, is to educate patients and let them understand kind of what their options are and how they can get better, and what the risks are, so they can make the best decision for them. So we'll talk about outpatient hip and knee replacement. We'll probably just start out by talking about hip and knee replacement itself, and then we'll kind of talk a little more how we've evolved over the last decade or so into this becoming a surgery that people go home the same day. So without further ado, we'll start out with hip arthritis. This is a picture of an arthritic hip. The hip is a ball and socket joint. So the ball sits on top of your femur or thigh bone, and the socket is in your pelvis, and that holds the ball in place right here. You can see this pink stuff right here, and then there's a line right here. That's all articular cartilage. So cartilage is a very smooth surface that when it rubs on itself, it moves very smoothly without any friction. So when you're healthy and you're young and you have nice cartilage, your joints move well. And so arthritis is one of the most common causes of pain. What arthritis is, it's a wear and tear that deteriorates that cushion, that cartilage in your joint. It's a degenerative condition that over time usually gets worse and not better. So arthritis can develop from abnormal anatomy if maybe you had a fracture or a dislocation or trauma to your hip joint that damages the cartilage. It can develop from abnormal biology if maybe there's a lack of blood flow to the femoral head in a condition known as avascular necrosis. Bo Jackson had that, and that's why he needed a hip replacement at a young age. It can develop from overuse. Or even genetics. We have a lot of patients that say, oh, I have hip arthritis. That's interesting. My brother had hip arthritis, or my mom had 2 hip replacements. So there's certainly a genetic predisposition as well. So again, the healthy end of each bone is covered with cartilage, so the joint functions without pain. And when cartilage breaks down, that leads to bone-on-bone contact, soreness, and swelling. So I liken it to a door hinge. This is a young person's hip right here. 20, 30 years old, brand new, and the door moves and shuts with full range of motion, doesn't make any noise, and there's no pain. But over time, we take normal function for granted. When you can walk and get in and out of a car and exercise or sleep without pain, over time, your joint can deteriorate to look like this. This looks like something out of a haunted mansion, right? It's going to creak, it's going to crack, the door's not going to open with the full range of motion, and there's going to be pain associated with moving this door hinge or hip joint. And so when we ask people about hip arthritis and the symptoms, we really want to know, how much does the arthritis that someone has affects them? Do they limp? Number one question is, do they have difficulty putting on socks and shoes? Difficulty with activities and lifestyle. Does one leg feel shorter? Are there balance issues? Most commonly, they'll complain of pain in the thigh, the groin, or the butt. Sometimes the pain can even radiate into the knee. Literally have people come in for knee pain to the office. Their knee looks totally normal, and we just say, humor me and get a pelvis x-ray, and they got bad hip arthritis. So these are the questions we ask where we can really sort of assess how much the hip arthritis affects a patient. So in good news, not every person with hip arthritis needs surgery. You can treat your hip arthritis and alleviate the symptoms using water therapy, like heat packs, ice packs, soaking in a hot tub. Exercise and physical therapy are good for the joint. The range of motion is actually healthy for the joint, and then also good for weight loss. Medications such as anti-inflammatories, Motrin, Tylenol can help. And then injections with steroids typically into the hip joint can also decrease inflammation and help with pain. Now, hip replacement is a procedure that you perform to replace the damaged surfaces of the hip joint. Helps to relieve pain and improve mobility. Pretty common. This number is probably old. I bet you there's probably 400,000 or 500,000 in our country every year. And so this is an alternative when those non-operative treatment options we just spoke about don't work anymore. So how does a hip replacement work? Well, here's that normal hip joint we saw earlier in the talk. And here's what a hip replacement is. So basically what we do is we make a cut on the bone right about here on what's called the femoral neck. And then we take this bone and we throw it away. So in surgery, you're looking at kind of the femur disconnected from the pelvis. And then what we do is we put a metal shell inside the pelvis, a plastic liner inside of that, and then a metal stem inside of the femur so you don't feel it or anything like that. And then a ball on top of that stem, and then that ball articulates with a liner. And now you have kind of recreated that natural hip joint, but instead of having bone rubbing on bone, you have ceramic rubbing on plastic. So here's a picture of an x-ray before surgery. Okay, it's arthritic. There's no space between the bones right here, bone on bone contact. You get cysts that form and you get what's called sclerosis or hardening of the bone. So if you take a cut right here, okay, and you take all this bone and you throw it out, then you can go over to this picture and that's the hip replacement. So there's the metal stem, which is white inside of your femur bone, the metal shell, which is inside of the pelvis, and then the ball that articulates with the liner in there. And you're really, again, just trying to recreate that patient's normal anatomy. One thing that's somewhat newer, but actually is just getting kind of old and routine, is called an anterior approach to hip replacement. It's a great way to do hip replacements because we can work between the muscles and tissues without detaching them from the thigh or hip bones. In a traditional surgery, patients are lying on their side and they have an incision that kind of goes on their side or back to their butt. In the anterior approach, which is something that I do, we have people lie on their back on this torture device called a fracture table. And basically what we can do is we can manipulate the patient's leg so that we can get into the hip joint without detaching any muscles. Additionally, I use x-ray during the procedure so I can kind of check component placement and leg lengths during the procedure. So I think this is a nice way to do hip replacement. This is what I do a lot of at Capitol Health Hospital in Hopewell. A lot of patients are very happy after their hip replacement. It's like 96 or 97% successful when we talk about to patients about their surgery. And it's really neat because a surgeon might think a surgery is successful, but the patient might not always agree. With hip replacement, there's a really high concordance there. Patients and surgeons typically agree that the surgery went well. So it's a really great procedure and really was dubbed the operation of last century because it's really allowed people to function later in life and allow people to recover, believe it or not, from hip fractures faster and easier and allowed people to stay mobile for longer. So in summary, the leading cause of hip pain is osteoarthritis. It's a degenerative condition that won't get better over time and it might actually get worse. Early diagnosis and treatment of arthritis are important, and hip replacement can help relieve pain and mobility. The best thing really is to, believe it or not, a simple x-ray will diagnose your hip arthritis. Physical exam is also key as well. So you don't need fancy MRIs or anything like that. And, start finding a diagnosis early is really helpful because you can treat it. And then as symptoms worsen, then, you have a pathway towards surgical treatment if that's what you ultimately need. Kristen, I was going to flip over to knee arthritis, but are there any burning questions about hip replacements in the chat?
Nope, nothing burning, just a question about knee replacement, so we can move on.
All right, well, whoever had the question about knee replacement, here we go. So we're going to talk about knee arthritis next, and we're going to talk about the knee and how it works, and basically kind of go through the same procedure we did with the hip. So here's your knee joint. Okay, it's the largest joint in the body. Here's your femur bone or your thigh bone, your shin bone or your tibia, and then the cartilage is in between, and your kneecap is in the front. And so, again, same thing. Most common cause of knee pain as we age into our 50s, 60s, 70s is osteoarthritis. It's a wear and tear condition that deteriorates the cushion in the joint. It's degenerative, won't get better, will probably get worse. Same thing as the hip. What does arthritis look like? This is an arthritic hip right here, or excuse me, arthritic knee right here, right? The cartilage, this stuff, is degenerated and damaged in all these spots. So that leads to abnormal contact and movement in the joint. So here's an x-ray of a normal knee right here. And where there's black space in between, that's representative cartilage. Here's an x-ray of an arthritic knee right here where the bones are touching. So when we ask patients about their knee pain, we ask, does it hurt 1 or more days per week? Does it interfere with sleep? Is it difficult to walk distances like more than a block? Do pain medications not help? Does knee pain limit you from participating in activities? And then the worst, has inactivity caused you to gain weight? So again, how can we treat this without surgery? Plenty of people can treat their knee arthritis without surgery. Principles are the same as hip arthritis: water therapy, heat, ice packs, aquatherapy, exercise, physical therapy, range of motion are actually good for your arthritic joint. For our patients with knee arthritis, I highly recommend an exercise bike. Great way to get exercise, but not necessarily use your body weight on your knee joint, which can aggravate it. Medications like anti-inflammatories, Motrin, Tylenol, Aleve, steroid injections are very common. And then in the knee, there's an injection called hyaluronic acid. There's a lot of different brands and names out there like Orthovisc, Monovisc, Euflexa, Gelson 1, Trivisc. They're all the same thing. And what they are, they're synthetic joint fluid that is injected into the knee joint that decreases inflammation, but also stimulates the production of more fluid in the knee joint. So that can hopefully provide some pain relief. Knee replacement is a great procedure that we can do once those non-operative treatment methods fail. Basically, we replace the damaged surfaces and help relieve pain and restore mobility. This number is probably old. My guess is there are 750,000 to 1 million done in this country every year. So it's becoming more and more common. So here's what a knee replacement looks like. So this is the end of your femur. And basically what we do in surgery is we cut the femur to accept this implant right here. And then same thing with the tibia. We cut the tibia, the shin bone, to accept an implant right here. And there's a keel that goes inside the tibia, so you don't feel that. And then there's this piece of plastic in between, and that's represented by this black space. So instead of having bone rubbing on bone, after the surgery, you have metal rubbing on plastic. And the hope is that'll allow one to function with less pain and more mobility. It's not going to be your knee from when you were 30 or 40 years old. But again, if we can get you to feel better when you walk and move and go up and down steps, that's the win. So again, here's an example of a healthy knee where you have a femur, a thigh bone, a tibia, a shin bone, excuse me. And the black space in between is the cartilage. Here's an example of a knee replacement. Here's the metal femoral component, the metal tibial component, and then here's the piece of plastic in between. So you are trying, again, to recreate the patient's normal anatomy. So in summary, the leading cause of knee pain is osteoarthritis, which is a degenerative condition that won't get better over time and will likely get worse. And early diagnosis and treatment are helpful because you don't have to live in pain. The non-operative treatment methods can absolutely help. So what can you expect after a joint replacement when we're talking about hospital stay, recovery, pain control? All these things are really important questions because these are things people fear, right? Am I going to stay in a hospital? Am I going to die? Is the pain going to be awful? Am I going to do physical therapy? Will I be able to get back to work? When will I be able to get back to work? I need money, right? So outpatient joint replacement has really become popular in the last 4 or 5 years, especially with COVID. Basically what it is we can now do joint replacements. And, when I started training in 2006 at Jefferson Hospital in Philadelphia with the Rothman Institute, patients would have hip and knee replacements. The hips would stay in the hospital 2 or 3 days. Some of them would go home. Some of them would go to rehab facilities for, 3 or 4 weeks. The knee replacements would stay in the hospital 3 or 4 days. Most of them would go to a rehab facility. And they'd stay there for 2 or 3 or 4 weeks. And now what we do is we actually do the surgery in the morning. We have you walk or stand that day, and we can even send you home the same day. Probably about a third or maybe even 40% of patients are going home the same day. It's more common now for a couple of reasons. Number one, we've gotten better at caring for patients from a standpoint of pain management, mobility, safety, and nausea management. Also, the pandemic kind of spurred really a bump in this. And because we weren't allowed to operate at hospitals because they were so concerned about staffing and rooms for COVID patients. So we were able to take these surgeries for people who really, really needed them and were really struggling during the pandemic and do them in outpatient surgery centers. And it's just become more common now. And to be honest, patients are more expecting this now because it's just nicer to go home and sleep in your own bed. Are you a candidate? There is some pretty strict criteria. We don't want patients who are, sicker or have, cardiac or pulmonary problems being unmonitored the night after surgery. So sometimes we'll tell people, no, you should stay one night in a hospital. But most patients are candidates. So the biggest key with outpatient joint replacement is safety. And patient education is really a part of that. So what are the expectations of the patient? The patient needs to know, they're going to walk with a walker probably for the first few days. They may need some help at home for the first few days with chores like taking out the trash or cooking. It's all about fall prevention and making sure that we avoid complications. So one way we do that is by patient selection. So we want low-risk patients to go home the same day. So in anesthesia, they use an ASA class, which basically 1 or 2 are like healthier patients, 3 or 4 are like sicker patients. Hemoglobin A1C less than 8%. So that means we want their diabetes controlled if they're diabetic. BMI of less than 40. We don't want people that are too heavy. We know that there's a higher complication rate in heavier patients. So they may be better off staying in a hospital one night. We want people smoke-free. Tobacco is absolutely an indicator of increased complications, whether you do this the same day or you stay overnight in the hospital. So we really want people to be tobacco-free for 6 months. And then an interesting one, anemia, meaning low blood counts. We know that anemia can lead to is associated with complications. So we want to make sure people have anemia corrected prior to surgery to avoid complications. Next, we have protocols to help decrease infection. Patients wipe down with Hibiclens or chlorhexidine wipes to decrease the risk of infection. They do nasal swabs to decrease the risk of infection. What you have to understand is bacteria live all over our body, on our body, in our nose, and that's all normal. The problem is when one of those normal bacteria on our skin get into our surgical site, that can cause an infection. So that's why we do all these cleaning protocols. Room and instrument cleaning as well. Same idea of making sure things are sterile so they don't introduce new bacteria into the surgical room. So part of that patient expectations, again, we need patients to prepare themselves. Patients have to really be involved in their care. They need to mentally prepare. They need to identify a caregiver or a coach. Our goal really is that prior to surgery, the patients don't have any questions about what's going to happen after surgery. And the real big key is the fear of the unknown. So pain, dependence on others, limited independence by not being able to drive. When am I going to go back to work? When am I going to feel normal? These are really common questions and concerns patients have after surgery. So when we talk about outpatient joint replacement, one of the keys is pain control. And so we do use what's called multimodal analgesia. So we give medication before, during, and after surgery to fight pain. And we give multiple types of medication to hit different pathways of pain in the body. So we'll review that now. And so what we can do is before surgery, we give medications like anti-inflammatories, anti-nerve medications, Tylenol. These things can all start treating pain before the surgical pain really even hits. We also can do nerve blocks before surgery as well to help keep the leg numb after surgery. Intraoperatively in surgery, we often do injections around the joint to help with pain. And then after surgery, a similar group of medications as before surgery. And then people have the nerve block on board and the periarticular injection on board. So all these things can combine to create an environment where a patient really doesn't have overwhelming severe pain after the surgery. So for outpatient joint replacement, it's really important that we work with our physical therapy team after surgery. I usually recommend pre-op physical therapy as well. Sometimes you'll need equipment after surgery, whether it be an ice machine, whether it be a commode or a walker. So we try to get people to plan ahead. We have the therapist come see you in the recovery room after surgery. And then we also have you practice on steps so that, if you have steps at home, you'll be able to navigate these once you leave a surgery center or a hospital. So how can you prevent a joint replacement? This is always like the last question I get when I do a lecture. Number one is to stay active with an exercise program. If you don't use it, you'll lose it. You'll lose range of motion as you get older if you're not staying active, and that can help lead to arthritis. And number two is weight control. For every pound we weigh, it's 7 pounds of force on the knee. So really important. And 4 pounds of force on the hip. So really important for people to control their weight and make sure they don't get too heavy because that can really exacerbate the issue of arthritis. Thank you. This was kind of what I had for you about hip and knee replacement and the new protocols that we have that'll enable patients to go home the day of surgery. Happy to entertain questions.
Okay, I have a couple of questions here for you. First question is, do you recommend in-home PT immediately after surgery? And if no, why not?
Usually not, and there's a couple reasons for it. Number one, I just don't know that those in-home therapists have the equipment to really help. So what I do is I give an exercise program to patients before surgery. So if they're well-versed in that, that's usually all they need for the first few days after surgery. And then I recommend my patients usually go to outpatient therapy 3 to 6 days after surgery. And part of the issue with outpatient therapy is that is therapy. Getting out of your house, getting into the car, walking into the therapy location. So again, I'm encouraging movement to help your recovery, which is why I don't recommend people kind of sit around the house and wait for that home therapist to come to the house.
Great. We have a couple questions about sleep. One is, can you sleep on your side after knee replacement? And then
I don't have a restriction on how you're going to sleep after surgery. The problem is if you lay on the operative side, it's probably going to hurt. If you lay on the opposite side, that may also hurt. You may get like a pulling sensation in the replaced hip or knee. So it's really tough to get comfortable. And sleeping is probably my biggest pain point after surgery, because patients often don't sleep well for 2 or 3 months after the surgery, even as their functional recovery is pretty good. So it's really tough, especially after knee replacement, to get a good night's sleep sometimes. And that's a real challenge.
Is there a difference in the pain level during the day versus sleep?
For some reason, patients will, post-op day 1, 2, 5, yeah, they tell us they have pain, sure. By, the next week or so, really, it's interesting. They'll say, doc, the pain isn't so bad during the day, but during the night, man, it's really aching. And so that's, again, a real pain point for us. We'd love to try to get that better. We haven't necessarily found that kind of solution to decrease the night pain. And then that leads into another thing as far as how long am I going to be out of work? I recommend everybody just take 3 months out of work when you're having a procedure like this done, because it takes time to recover. There's stiffness, there's soreness, there's swelling. And if you're not sleeping, it makes it really hard to work. So I recommend everybody just start out with 3 months. And if they can get back sooner, that's fine. Nobody's ever concerned about that. But it's a lot easier if you just tell your HR department you're taking 3 months out.
And just to go along with that, how long until you can drive after a knee replacement?
Everybody's a little different in kind of what they feel is safe driving. For example, I would not drive with my mother, even though she doesn't have a knee or hip replacement. But regardless, yeah. So I really tell people, look, 2 weeks is probably reasonable to get them behind the wheel, though it may not be realistic. Sometimes it's hard to kind of get in and out of that driver's seat. Sometimes you don't feel the confidence that you're going to be able to slam on a brake. And then sometimes you might still be on narcotics. So cops don't like it when you drive while taking narcotics. So 2 weeks is a reasonable goal, but not everybody kind of is ready to drive at the 2-week mark.
Is there a specific exercise you recommend for arthritic knees?
Yeah, I recognize a whole group of exercises, which I give to all my patients before surgery. Additionally, if you go to the American Association of Hip and Knee Surgeons, they actually have a patient guide there with a whole physical therapy guide for patients with arthritic knees and hips.
Okay. Is there an example like swimming, or is there anything specific that you recommend?
For arthritic knees and hips, absolutely. Exercise bike or a bicycle is the best, because you can really push and really get that heart rate up. And it doesn't really hurt the knees that much. Swimming and ellipticals are also great. Highly recommend against walking on the treadmill or running if you have an arthritic knee. But you can do it. I just think you'll pay for it.
And 2 questions about bilateral knee replacement. And then I'll get into the rest of the person's question, but there's 2 people asking about what your thoughts are on bilateral knee replacement.
Yeah, I hate bilateral knee replacements. I don't do them. I just think it's really hard, and those patients really struggle because one knee replacement is hard enough, so doing the second is tough. I also think there's a higher rate of complications, whether it's bilateral hip or knee replacement, because inherently you lose more blood by doing 2 surgeries. And we do know that, anemia or low blood counts actually is associated with a higher rate of complications. So I really discourage everyone from doing both at the same time. And I don't think I've done it for anyone in about 3 years.
Can you discuss the relationship of having knee osteoarthritis first and then the impact on the hips?
Good question as far as does knee arthritis cause hip arthritis or vice versa? And we don't really know the answer. What we do know is we see oftentimes that arthritis is kind of the gift that keeps on giving. So if you have it in your knee, you'll develop it in your back, and then eventually develop in your hip, and then maybe your hands. So no clear correlation, but we certainly see, or no defined correlation, but we certainly see it.
Just want to get all the knee questions done. I think weather sensitivity after joint replacement.
Yeah, and this is actually before joint replacement too, because our arthritic patients will tell us all the time that they can feel it. They know when the cold, damp weather is coming, and unfortunately, you still have that barometer effect when you have a knee replacement, oftentimes as well. I theorize that may be why a lot of people, as they age, move down to Florida or the Carolinas, those warmer climates, because that cold, damp weather can absolutely cause their joints to ache.
Another one, I think this might be my last knee question. X-ray of the knee replacement, the space that appears empty between the components where the meniscus used to be, does it look empty because the plastic doesn't show up on an X-ray?
Exactly. Very good.
Okay, now we'll move to hips. How is the decision made for interior versus posterior hip replacement?
So the patient's asking a question about different approaches to the hip joint. There are three main approaches: anterior front, lateral side, or posterior back. They're all very successful and they all do well. So the question is, how do I decide which approach I get? Well, in good news, you don't have to make the decision because your surgeon's going to make it. Usually a surgeon is really good and well trained at one or two of these approaches. And so I just tell patients, look, just do whatever your surgeon tells you to do. If you are specifically looking for a specific approach, you can certainly kind of search people out on the internet and seek them out. I do an anterior approach for most of my hip replacements, and I do a direct lateral for the rest. I do not do a posterolateral. That is actually the most common one in the world, probably. But the other approaches are really catching up quickly in frequency to the posterolateral or the classic hip approach.
And after hip replacement, when can you bend greater than 90 degrees?
So what someone's talking about is called hip precautions, where after the surgery, we want things to kind of scar in sometimes so that you don't, so that if you bend or twist, you don't dislocate or pop the ball out of the socket. I'm sort of ambivalent on that. I don't necessarily believe that the precautions really protect people that much, but a lot of times a rule of thumb will be like just protected activity or protected weight bearing for like 4 to 6 weeks.
Okay. Any other limitations after a hip replacement? Range
The
of
goal
motion,
is not too many, but
lifting?
both hip and knee replacement are absolutely a process. It's not like you get the surgery and you're better the next day. They take time, they take therapy, they take rehab. Their legs are often stiff, swollen, and sore. So it can be challenging, but it usually just takes time. And believe it or not, while most of your functional recovery is going to happen in the first, probably 1 to 2 or 4 months, you can actually still get improvement for up to 1 year after the surgery. So it does take quite a while to get the maximum benefit from the surgery.
What would you say are the biggest risks of a hip replacement besides infection?
So infection is going to be one of your biggest risks for any type of surgical procedure, and unfortunately, hip and knee replacement are included in that. Other risks for hip replacement, when we're talking about orthopedic procedures, especially putting in implants, periprosthetic fractures, so meaning a fracture around the implant or the plate and screws or whatever. So that's a tough problem that, it can be challenging to deal with. I did a fellowship in hip and knee replacement, an extra year of training, so I'd be well versed in those types of problems. And even for me, they still can be very challenging cases. Additionally, for a hip dislocation where the ball pops out of the socket, that's typically a bad problem. Usually a patient has to go to the hospital to get it popped back in. And sometimes they may even need like a second surgical procedure, just like for the fractured femur.
Here's a question I haven't seen before. What are main complications with an anterior approach? And this person, it's a physical therapist, they have read that impotency is a possible low risk. Do you know anything about that?
I have not heard about impotency as an anterior approach complication. I guess in theory, if your incision really strayed from where it's supposed to be, you could end up cutting like the spermatic cord or something like that, but I've never seen or heard of that happening. Probably more commonly, if we're going to talk about complications with an anterior approach, sometimes, whether it's exposure or bone quality or whatever it is, sometimes you can be more likely to sustain a fractured femur in an anterior approach. Data hasn't really shown that to be true totally, but there could be a slightly increased incidence. What there is an increased incidence is the rate of wound complications. So that anterior hip wound is kind of right on the front of your thigh. And a lot of times, if you have a little bit of a belly, that your pannus will actually lie flat and kind of overhang and kind of irritate or macerate the incision. And that can lead to wound healing problems. So wound healing and periprosthetic fractures are probably the number 1 and 2 complications from anterior hip replacement that we see. From the standpoint of posterior hip replacement, excuse me, one of the more common complications is dislocation. That's where the ball pops out of the socket. That being said, it's still pretty rare. Dislocation rates, even in a posterior approach, are probably less than 1%. So what it really comes down to is that all of these approaches have pros and cons, but none of the pros or cons really outweigh the others. So it really comes back to choosing a surgeon who, then just let them do the procedure that they do. Or if you specifically want a certain procedure, then seeking out surgeons who do it.
Okay. And we have a couple people asking about pain medication after. Are we taking NSAIDs? What are we taking?
Yeah, so pain, it goes back to that multimodal analgesia. So we're taking NSAIDs, like a Celebrex or a Mobic. We're taking Tylenol, a lot of times taking a narcotic like a hydrocodone for maybe the first week. Nerve medications are also helpful, like a gabapentin or a Lyrica.
My bedroom is a full flight of stairs upstairs. What can I do?
You can walk up your steps. And that's what we do. With therapy after surgery, we train you on steps. You can try to combat it by going to therapy beforehand to understand how you're going to walk with your new hip or knee. For the most part, it's leading with a good leg and following with the operative one. But you can absolutely go back to your place, the day of or the day after surgery, even if you have steps.
Is there any specific equipment that you'll need after knee surgery? Walker, cane, knee
Most
walker?
commonly a walker. Sometimes people will want like a 3-in-1 commode, so they don't have to go all the way to the bathroom. And then a cane may be helpful at some point as well. Canes are not covered by insurance. Everything else, has the potential to be, but insurance companies don't really want to pay for anything, so they just say it's uncovered. So it may or may not be covered.
After my first hip surgery, Dr. Saxena recommended no flying for 3 months. Does this still exist?
It does. I make the recommendation, and if I held you from a trip, I apologize. But I make the recommendation just from a safety standpoint and a standpoint of like, look, if you call me from Mexico 2 weeks after your surgery, there's nothing I can do to help you. So ideally, I do like my patients to stay in town for at least 6 weeks, 2 months after the surgery. If you're doing well, if there's an emergency, fine. And you have to leave town, that's fine. But ultimately, again, I want to be there for my patients. So if you leave town, I can't be. That being said, all over the world, people do fly in to New York or Philadelphia, have a procedure done, and then go home 2 or 3 days later. So it's a reasonable thing to do if you have to or really, really want to. But ideally, I'd have my patients staying around town for at least 2 months after the surgery.
Thoughts on COVID vaccine? Should it be avoided before surgery?
Yeah, as far as the COVID vaccine, I don't really have any thoughts on whether or not it should be avoided before surgery. What we do know is that patients with COVID infections have worse outcomes after surgery. So we usually want people to be COVID free, and we still have a process where we test people for COVID prior to surgery at some facilities.
I'm a diabetic and I have a stent in my heart. Can I go home on the same day?
Ideally, no. We'd probably want to watch your blood sugars. We'd probably want to monitor you overnight with the cardiac stent. So probably not.
What are your thoughts on plasma injections?
So plasma injections, probably referring to PRP injections. These are medications or therapies where people take blood from you, spin out the nutrients that kind of have the healing processes like the platelets, and then inject them into an area of the body where there's degeneration. So it could be, a tendonitis in your Achilles. It could be arthritis in your knee. Here's my take on these things. Number one, they're not going to fix the problem. Nothing's going to regrow cartilage. So if you take a PRP injection and you get a couple weeks or months worth of relief from it, that's great. But it's not going to fix the long-term problem. So that's sort of my take on these, the biologics, whether it's PRP, whether it's stem cells. There's just so much we don't know about these things and how they work and what conditions they work best in. So the data really isn't there. So if it's something you want to try, it's reasonable to try in the hip or the knee. But I always tell people, look, if you're going to go somewhere and they're going to do this for $1,000, ask them, if it doesn't work, do I get my money back? And the answer is always going to be no. So it's worth trying, but certainly it's risky. I wouldn't anticipate that these PRP injections, stem cell injections, really any injection are going to do anything more than some temporary symptom relief.
And a couple questions about materials. What type of adhesive are you using? And do you use metal or plastic? This is all for knee replacements.
Yeah, so for knee replacement, we do metal and plastic typically. The components are most commonly grouted onto the bone with a polymethyl methacrylate or bone cement. In some cases, we can do what's called a press fit, where we don't use any cement and the implants just kind of stick on there because they have like a grit blasted surface that's roughened and allows them to just kind of fix to the bone. Where was I going with that? Oh, yeah. And then the knee implants or the metal parts are usually cobalt chromium and can have nickel in them as well. So if someone has an allergy to nickel or cheap jewelry, we can do a different type of component that may avoid any complication of having a possible allergy to a metal. When I say possible, it's because some data suggests that these metal allergies aren't really things, that it's not really real, but it seems to me like there's probably some validity to it. As for the hip, we don't typically use a bone cement. Typically, the components are press fitted in, which means like if we make your acetabulum, we ream it to a size like 54 millimeters in diameter. Means we'll put in a 56. So we'll just kind of jam in just a size, a millimeter or two up to get for better fixation initially, and long term as well.
Will a hip replacement negatively impact a non-dialysis patient who has kidney failure?
Will a hip replacement negatively impact them? No, but could surgery, where there's a shift in fluid, and now all of a sudden you're a non-dialysis patient. Now you need dialysis after surgery because you're dehydrated or something like that. That's always possible. So that's a concern for someone on dialysis, or kidney problems. Is what are the post-operative shifts going to end up looking like?
How many PT sessions do you usually recommend after surgery?
For hip replacement, I recommend none. I recommend people just walk with a walker and then naturally progress over to a cane. For a knee replacement, I usually recommend anywhere between like 10 and 20. But every patient's a little different. Some patients are really motivated and have equipment at home and can do much of the exercises on their own at home, which is fine. Others might need to go to a gym more regularly, like 3 times a week.
How does the design of the implant affect stress distribution and bone remodeling in the hip joint?
Oh, wow, that's a tough one, huh? So the implants are designed to really minimize stress in the joint. They're designed to actually have the bone grow into the implant, so it really just becomes one with the bone.
Can patients take medical marijuana for pain management prior to surgery?
Yes, I have no issue with that. Just, you need to let the team know that's what you're doing. Anesthesia may have some parameters about it, which they say no marijuana within 7 days or something like that. Really just depends on your facility and the doctors that are there. Unfortunately, we don't have great data on a lot of this stuff, so some of it is just sort of trial and error.
What are your thoughts on acupuncture?
Acupuncture is a great tool. It's not going to fix arthritis, but if it can alleviate your symptoms and allow you to move on for, a month, a day, a week, whatever, it's a great tool.
How long can you expect a knee replacement to last?
Yeah, knee and hip replacements can be expected to last 80 to 90% of the time for 20 years. Doesn't mean they're failing year 20 and day one. It just means that's kind of the data that we have. So we hope that we'll see more, 95 and 100-year-olds with hip replacements that were done, 30 and 40 years ago in the future. But again, we have good data that shows the last 20 years.
Would waiting too long and having a more damaged hip make the surgery more difficult?
It certainly could. In most cases, it likely would not, but it certainly could if it was like an extreme situation.
Is there a specific brand of hip that you usually use?
I use a couple brands. They're all the same. If there was one brand that was better than the other, we'd all be using that brand. So it doesn't really matter.
Just a couple more here. How many hours after hip surgery are patients usually released from the hospital?
Most of my patients, if they have their surgery like at 6:30 in the morning, they're usually out of there by like 1 in the afternoon.
So fast.
And in a surgery center, we can do that even faster. There's just less barriers.
Should I go for a total knee replacement instead of a partial?
Depends on what your x-ray looks like, and it depends on what your symptoms are. I didn't talk about partial here, but it's a great procedure that I love to do. And if you can locate your pain on your knee with one finger, it's a good sign that the partial knee replacement will help you. If someone says, "Hey, where does your knee hurt?" and you just rub your hand all over, it's a good sign that the partial knee replacement might not work for you. Maybe you're better for a total.
We know you don't like to do a bilateral replacement, so how long in between the two would you recommend?
I recommend you give your body a chance to recover, which usually, if you're talking about red blood cells, your hemoglobin, the blood that you lost, recovering that takes about 3 months. It takes about 120 days to build a red blood cell, and they're kind of coming in as you have your surgery. So about 3 months is usually a reasonable time to go back in.
And finally, do you do robotic assisted surgery?
I do, and robotics are really a hot topic in orthopedic surgery right now. They can be very helpful in performing surgery. They're a great tool. The one thing people should understand is your surgeon is still doing the surgery. Your surgeon's still doing the surgery, and the robotic arm or the robotic assistant is a tool. So your surgeon is still doing the surgery.
So that looks like all of the questions. I put my contact information in the chat. So if you would like to schedule an appointment with Dr. Saxena, you can reach out to me directly and I can get you on his schedule. If you have any other questions, you can also email me or call me and I can reach out to him to get those answered for you. But thank you everyone for joining us.
Yeah, these were all great questions. Thank you. I hope you guys got some benefit from it and just sort of understand a little bit more about the surgeries. And really just, I feel very thankful that I'm able to do these surgeries for people because they really help people just kind of move on with their life and do the things they want to do without pain. So thanks for listening. Thanks, Kristen.
Wonderful. Thanks, Dr. Saxena.
All right, bye.
Bye.